Welcome back, everybody. David here again with Med School Boot Camp. So in this next video on our childhood musculoskeletal pathology, we're going to talk about Osgood Schlatter disease, a very common condition of the knee. Now, when we think about the knee, we have to remember our primary structures, which include the femur, the patella, the tibia, and the lateral bone, which is the fibula. Additionally, a key point I've talked about in some of the previous videos is that anytime when somebody presents, particularly a pediatric patient, but really anybody, any age with knee pain, you want to also look at their hip. There can very commonly be compensatory mechanisms. Vice versa is also true. If somebody presents with hip pain, you want to look at their knee as well for similar reasons. Additionally, knee pain has a pretty vast differential diagnosis. So the primary things you want to keep in mind are going to be the patient's age, history, and exam findings, right? If a patient is 8 years old, I really don't think that they have osteoarthritis first thing, right? There's definitely conditions that could make this more likely, but somebody who's 80 years old, I definitely think they might have arthritis. So you want to think about the age. You also want to think about the history, right? Do they have history of trauma? Do they have history of infections? Do they have history of joint replacements? Do they have history of genetic conditions or collagen defects would be really important. And then the physical exam is going to be important. What kind of motions are painful for the patient? What areas specifically are tender? Is there point tenderness in a specific area, or is the entire joint painful? These are the things we need to think about when we consider our differential diagnosis, because we could be dealing with so many different conditions, including osteoarthritis, rheumatoid arthritis, septic arthritis, juvenile idiopathic arthritis, meniscus tears, patellofemoral syndrome, ligament injuries, etc. And because the differential diagnosis for this condition is so vast, we have to know one or two key things to really differentiate one condition versus the other. So with this condition, when we talk about the etiology here, we keep in mind the age range of approximately 8 to 15 years old. In general, this is typically the age range of puberty and growth spurt and a lot of activity, and this is important when we think about the pathophysiology of the condition as well. These patients have an increased risk during these growth spurts and with repetitive movements, specifically sports participation, right? Very classic sports that have repetitive movements are going to be things like basketball, volleyball, some events in track and field, right? Anything where we get the repetitive motion on the knee can increase the patient's risk for having this condition. Now, when we think about the pathophysiology here, it nicely explains what's going on. A repetitive force to the tibial tuberosity, which is kind of the anterior portion of the tibia. It's the tibial tuberosity. I'll label it with 2 T's so you can see it clearly. What happens is that the repetitive force to this area from the patellar tendon traction, and again, we said this was the patella, so this right here is the patellar tendon versus up here is going to be the quad tendon. And so the increased patellar tendon traction leads to increased microtrauma and ultimately a microavulsion. Avulsion is actually pulling off of the bone. So an avulsion fracture is when a bony fragment actually separates from another area of the bone. Now think about it, right? Who's more likely to have these things happen? Who's more likely to have a repetitive force where the muscle is contracting, right? The quad tendon is going down and pulling on the patella is going down and pulling on the tibial tuberosity, which ultimately causes this avulsion fracture to occur. Well, patients who play jumping sports are more likely to have this occur, right? There's more of that repetitive pressure to this area, increasing their risk overall. Now, when we think about the presentation, these patients often present with anterior knee pain, which makes sense, swelling, tenderness, and enlarged palpable tibial tubercle. So if you draw your attention over here to our knee model, you can see this bump on the knee. This is a very classic finding, right? If somebody has continued patellar traction, that ultimately pulls this off the bone, right? The patella keeps contracting time and time again. It actually pulls off the tibial tuberosity, which often is not yet ossified at this age range, which is why children of this age are at a higher risk than, say, adults where the tibial tuberosity and the growth plates have actually ossified. Well, if this occurs where the tibial tuberosity is pulled off the bone, instead of having a flat appearing area right here, you can appreciate the bump portion right here. It's very common in high school athletes. You can see it, you can feel it, and for them it can be very painful and even debilitating at times. Now, another key thing I need you to know is that pain worsens with activity and with resisted knee extension. And again, this should make sense to us, right? Think about knee extension is the knee going away from the body. Where's our lever going to be? We don't need to get in the physics of it, but essentially for the knee to extend, for the knee to kick out this way, what has to happen? The quadricep muscles up here have to fire and activate. This is going to create a pulley system, which actually pulls the leg outwards into extension. Now, if this system is avulsed or there's a lot of pain right here, what's going to happen? Well, as the quadriceps fire and you send the biomechanical forces down to extend the knee, well, you're going to aggravate this area that's already inflamed, avulsed, and fractured in the first place. When we think about the diagnostics here, this is often a clinical diagnosis. That is to say, if patients present with a history, a physical exam that is consistent with this condition, you don't necessarily need imaging to confirm it, right? Again, this is a very classic presentation that patients will have along with these symptoms that they will be reporting in the office. Now, Patients may get an x-ray showing an elevated tibial tuberosity, soft tissue swelling, and possible fragmentation. So we've already kind of drawn our attention to this image, but the one I'm highlighting here in blue shows us very clearly someone with Osgood-Schlatter disease. Now, again, just to orient ourselves, we got femur, patella, tibia, fibula, tibial tuberosity, quadriceps tendon, patellar tendon, and a very obvious avulsion fracture. Again, bones we can see very clearly in white, tendons not so much, but you can imagine there's a quad tendon right here, the quadriceps above it connects to the patella, and then below the patella is a patellar tendon that actually attaches to this area right here. So repetitive motions that require extension of the knee or activation of this pulley system is going to cause an increased trauma to this area and ultimately increase the patient's risk of developing this condition. Now, when we think about the management here, pretty straightforward. Conservative treatment is typically the way to go. So RICE is a very common acronym that stands for rest, ice, compression, and elevation. Again, a lot of conservative management. NSAIDs or anti-inflammatories can be helpful. This can cause a lot of inflammation and pain in the area. And additionally, stretching and strengthening can be helpful, particularly focusing on the quadriceps muscle itself. Now, in severe or extreme cases, surgical intervention may be necessary. However, this is really reserved for a last-ditch effort if patients are just not having any improvement with conservative measures and it's becoming a hamper on their life. Then you may consider surgical intervention, but this is absolutely not a condition that you want to jump to surgery in any way, shape, or form. This is typically going to resolve in adulthood or once the bone has fully matured. So just a quick summary to wrap up this video. Fairly short one, we have Osgood-Schlatter disease. It's one of our childhood musculoskeletal pathologies, but it should be considered in the context of a very vast differential diagnosis for knee pain. We talked about some of them here, but this is not an exhaustive list. Etiology, typically it's going to be in a younger patient, often in a growth spurt, an active patient that plays in a lot of repetitive sports such as basketball or volleyball. Pathophysiology is due to repetitive force to the tibial tuberosity, kind of this anterior portion of the knee, leading to patellar tendon traction, microtrauma, and ultimately a microavulsion. The presentation here is going to include anterior knee pain, swelling, tenderness, and an enlarged palpable tibial tubercle, a very classic finding you can see on physical exam. These patients will also have worsening pain with activity and resistant knee extension. Why? Because we're activating this pulley system. We're putting more pressure on it when we're trying to extend the knee outwards. Often this is a clinical diagnosis. However, x-ray can be useful if you're kind of unsure what the patient might have. And a classic finding is going to be this elevation of the tibial tuberosity. Management here, typically we want to do conservative management almost always. However, in extreme cases, surgical intervention may be necessary. So how might they ask you about this in a question stem? Well, they might ask you something along the lines of, an 11-year-old patient presents to the pediatrician with left knee pain for 3 weeks. The child has no remarkable health history to report. He recently joined the school's basketball team and states he wants to go pro. On physical exam, there is full range of motion of the knee, no ligamentous laxity, along with tenderness to palpation over the tibial tubercle. The patient has 5 out of 5 strength with resisted knee flexion and extension, but reports it is painful during knee extension. The question could then ask, which of the following is the patient most likely to be experiencing? So there's a couple key things here that we need to keep in mind. One is the patient's age, right? This is an 11-year-old patient, making things like osteoarthritis less likely. This patient recently joined the basketball team, so they're definitely involved in repetitive sports. There's no real mention of fevers or other illness going on, so we can kind of rule out things like a septic arthritis seems unlikely. And the physical exam talks about the patient having full range of motion, but there's pain on resisted knee extension, right? This is very consistent with the diagnosis of Osgood-Schlatter disease, which is what this patient most likely has. If we were thinking about some other things like a meniscus injury, an ACL, PCL, or ligamentous injuries, we'd get some other findings in the question stem as well. However, these were not reported, so we cannot make any assumptions about this. Therefore, the best answer for this patient who's in this approximate age range, in a repetitive sport, and has resisted knee extension pain, along with a palpable tibial tubercle, they most likely have Osgood-Schlatter disease.